This video is on disorders of the B and T cell. So we're going to talk about B cell disorders. We're going to talk about T cell disorders. And then we're going to talk about both B and T cell disorders. Now your B and your T cells work together, and they work together to fight all different types of pathogens, bacteria, viruses, fungi, parasites, all that stuff. But in certain pathogens, you have more pronounced B cells or more pronounced T cells. For example, bacteria usually have a little bit more B cells. Viruses, we said that your CD8 killer T cells, cytotoxic T cells, handle that, so that's T cells country, and also fungi is T cell country. If someone has recurrent viral and fungal infections, you might be thinking more T cell. If someone just has bacterial infections, but they can fight viruses and they can fight fungi right away, you might be thinking more B cell. Okay, so that's just some hints that can guide you. All right, so let's talk about B cell disorders. First one I want to talk about is X-linked agammaglobulinemia. Judging by the name, what do you think this is? Well, I think it's going to be an X-linked disorder, and I think it's going to be a lack of immunoglobulins in your blood. Just judging by the name, and I would be right. This is an X-linked recessive disorder, which is codename for it's found only in boys because women have 2 X chromosomes, and if it's X-linked recessive, then the dominant X chromosome will kind of hide it. But boys, men only have 1, so this is only found in boys, so sons. And it's a mutation in the BTK gene, and BTK stands for Bruton tyrosine kinase, and this tyrosine kinase matures B cells. You can't mature B cells, you don't make those B cells, you don't make immunoglobulins. You get agammaglobulinemia. So decrease B cells, decrease immunoglobulins. Hopefully no problems there. And this is all classes, all immunoglobulin classes. It'll show up after about 6 months of a baby's life. So after 6 months, why is that? Remember, your maternal IgG will travel to the baby, give it some immunity, give it some protection for that 6 months. But after that 6 months, the IgG goes away, baby is no longer protected, baby no longer makes B cells or immunoglobulins at all. They have X-linked agammaglobulinemia. Cool. Second one I want to talk about is selective IgA deficiency. Judging by the name, what do you think happens? You're going to have decreased IgA. Decreased IgA. Now, tell me everything you know about IgA. Give you a second. All right, IgA found in your mucous membrane. So if you have decreased IgA, won't you have more respiratory infections? Won't you have more GIT infections? It's related to atopic diseases. You can get allergic immune responses to allergies or rhinitis or whatever, but you can also get it to blood transfusions. You can have an allergy to blood transfusion. Why is that? Well, if your body has no IgA and someone gives you blood full of IgA, your body freaks out. It's like, what is that? I've never seen that in my life. What is that? And then we'll attack it. You'll have a blood transfusion reaction. I'll talk a little bit more about that in a subsequent video, but very important that you're able to kind of understand that. So someone with recurrent infections given a blood transfusion and they react to it. IgA deficiency. Easy peasy. Last one is going to be common variable immunodeficiency. This is multifactorial problem with class switching. That seems kind of generic, not very specific, and that's exactly what you see. Sometimes some people might have decreased IgG, some people might have decreased IgA, some people might have normal both, but they have decreased IgM. It's variable, that's why we call it variable. Whatever the case, there's some sort of dysfunction in your B cells, decreased B cells, some sort of dysfunction in your class switching, so you have some sort of decreased immunoglobulin. So it could be variable, but this is what they have in common, This is a diagnosis of exclusion after you exclude these 2 more common ones, all right? These 2 more common ones. Let's just go over it one more time. Kid comes in, you look at the labs, they have decreased all immunoglobulins, and then they might ask you what is the mechanism, mutation BTK, or they might ask you what's the inheritance pattern. It's X-linked recessive, only seen in boys. Patient comes in, recurrent infections, you draw labs, only see decrease in IgA, IgA deficiency. And then they might ask, all right, what are you trying to avoid? Blood transfusion, stuff like that. Patient comes in, has really wonky immunoglobulins, but some of them decrease. Common variable immunodeficiency. That's B-cell disorders. Let's talk about T-cell disorders. T-cell disorders, we said T-cells help fight viruses and fungi. So in the history stem, they'll talk about recurrent CMV virus, HSV virus, fungal infections. You're thinking T-cell disorders. First one, 22q11.2 deletion, better known as DeGeorge syndrome. And this is a deletion of about 40 genes in chromosome 22. That's a lot of different genes. But pertinent to our immunology talk is the fact that your third and your fourth pharyngeal pouch doesn't develop. And this helps make your thymus. Doesn't your thymus mature your T cells? That's what we're talking about in T-cell disorders. So you don't have a thymus, you don't have T cells, you get those recurrent infections. Now your thymus as an adult is basically non-existent, but as a kid, it's really big, growing really fast, revving up. And so if someone has what you think is a thymic disorder, you'll do a chest x-ray. Make sure you see that nice big thymus. If that thymus is gone, then you know something's wrong with the thymus. You're thinking this, okay? So in these people, they have decreased T cells and no thymus on chest x-ray. They sometimes call it no thymic shadow. They don't have a thymus because they're not developing. Your thymus is not developing. Now your third and your fourth pharyngeal pouch also make your parathyroid. Your parathyroid makes PTH, which creates bone resorption, releases calcium into your blood. Without your parathyroid, you don't have PTH, you don't have calcium, so you get hypocalcemia. Hypocalcemia. And then some more kind of general things. You can get cardiac anomalies like tetralogy flow. You can get abnormal facies. If you're deleting over 40 genes, you can imagine there's going to be a lot of different systemic manifestations. So you get all these things. Let's try and make it into a step-like question. Person comes in, recurrent infections, you do a chest x-ray, no thymic shadow. What pouch did not develop, third and fourth? Or what else do you find on labs? Decreased PTH, hypocalcemia. Or patient's also cyanotic. What might happen? Look for some cardiac anomaly, okay? So jump all the variables up, try and make a step-like question in your head. Makes things easy to remember. The second and the third one are very similar. They deal with decreased IL-12 function, and they have slightly different mechanisms. So the second one we're going to talk about is going to be IL-12 receptor deficiency. So IL-12, the levels are normal, but it's not hitting the receptor, or there's not enough receptors, or there's some sort of mutated receptor. So IL-12 receptor deficiency, and you should remember IL-12 induces Th1 cells and produces INF, interferon gamma, that revs up and recruits macrophages, causing granulomas, and attacks things that might cause granulomatous diseases. Things I can think of is how about mycobacterium, how about fungi. Anytime you have mycobacterium, anytime you have fungi, you get caseating granulomas. And if you're not able to do that, you're going to have recurrent infection of said disease. So mycobacteria and fungi. One of the things they like to ask is, what's the first sign that someone might have IL-12 receptor deficiency? The first sign is when you give them a routine tuberculosis vaccine, BCG vaccine. We can't do that, right? We have a receptor deficiency. We're predisposed to this. So you give them that and they have an adverse reaction, you're thinking IL-12 receptor deficiency. Easy peasy. Now, the third one we're going to talk about, something's wrong with the IL-12, right? But the mechanism's a little bit different. This is called hyper IgE syndrome. This is a mutation in STAT3. And STAT3 controls cytokines, and it controls growth factors. Cytokines and growth factors. In particular, the cell T helper 17 cell can't release these. And T helper 17 is just is a T helper that releases interferon 17. You don't need to know what interferon 17 does, but it affects the cell. And there's a mutation, and it can't release cytokines, can't release growth factors. Well, some cytokines that it can't release will be IL-12, or interferon gamma. And so you get similar signs. You get recurrent infections. But it can also not release general cytokines that cause inflammation, that cause neutrophilic chemotaxis, pull neutrophils in. And what you get is cold infections. Infections and abscesses that aren't inflamed, that aren't vasodilated, that don't hurt. Why? Because you don't have the cytokines that pull in neutrophils, that cause vasodilation, that cause all these things. You have a mutation in that. So you get cold infections. And we said that IL-12 induces Th1. Well, if you don't have IL-12 because you're not making it, then you don't have Th1. Decreased Th1. But you will have increased Th2. You kind of throw off that balance. And Th2 can do a lot of things. It can also increase IgE and eosinophils. So you have patients with things like eczema, because eczema seems to be really highly correlated with IgE and eosinophils, right? Atopic disease. So that's this whole cytokine part, right? The cold infections, the fact that you throw off the balance, causing increased IgE, that's why I call it hyper IgE, and eosinophils, eczema. Eosinophils, eczema. How about the growth factor part? You mess up your growth factors, you mess up, and you get really strong MSK abnormalities. You get coarse facies. You get retained primary teeth. You get fractures. Right, so it's not just recurrent infections. You get a question with someone with recurrent infections that get eczema, that have a coarse face, fracture easily. You're thinking, oh, there's something wrong with cytokines, there's something wrong with the growth factors. That must be hyper IgE syndrome. All right, and then they might ask you, what do you find on labs? Increased IgE, increased eosinophils. Or they might ask you, what's the mechanism? STAT3 mutation. All right, let's move on to our last one. This is called chronic mucocutaneous candida. There's a dysfunction in your T cells for whatever reason, multifactorial. And because your T cells fight fungi, and candida is a fungi, you can't fight candida. And so as you see candida all over your skin, all over your mucous membranes, skin, mucous membranes, but it's not invasive, it's not getting into your blood, it's not, causing sepsis or anything. It's just, you get chronic candida all over your skin, all over your mucous membranes. What do you think it is? It's going to be chronic mucocutaneous candida, right? Just looking at the answer choice, you should be able to get that one right. And if you mix candida with T cells from this patient, there will be no reaction. T cells are dysfunctional. That's B cell disorders. T cell disorders, let's talk about combined B and T cells. Wow, look at this wall of text. Holy crap. Combined B cell and T cell disorders will be easy to pick up because in the history stem, they'll talk about someone that has recurrent bacterial infection, that's B cell, and then recurrent fungal and viral infections, that's T cell. So you're like, whoa, both their B cells and their T cells are shot. So someone that comes in with recurrent strep infections, and also candida infections, and also HSV infections, what do they have? They have combined B and T cell disorder. The first one is SCID, severe combined immunodeficiency. What a fitting name. There are several causes. IL-2 receptor mutations, especially in the gamma subunit. That's just a subunit of your receptor. IL-2 is an incredible cytokine that induces basically everything. So you have a receptor deficiency in that or a mutation, you don't get your B cells, you don't get your T cells. This is the most common cause of SCID. You can also have adenosine deaminase deficiency. Is like a throwback to our biochem videos. Maybe one of the first biochem videos I ever made. I'll link it on the description, but adenosine deaminase is used in your purine salvage pathway. Keeps your purines there. You know, purines are used for DNA synthesis. It just so happens that your B cells and T cells are so mitotically active that are proliferating so much that they need all this DNA. If you have a deficiency in that, then you won't be able to make your B cells and your T cells. You get SCID. You get SCID. They may want you to know that this deficiency is autosomal recessive. IL-2 receptor is not autosomal recessive. What do you think do you see on labs? It's not a trick question. You're going to see decreased B cells, you're going to see decreased T cells. They might not ask you that. They might ask it to you in a more tricky sense. They might say decreased follicles. What do follicles contain? That's your B cells. Or they might say no thymus. What does your thymus make? T cells, right? Or they might say decrease T cell receptor excision circles. And you're like rolling your eyes. What the heck is this? Why do they have to make things so complicated? T cell receptor excision circles are little circles of DNA that are found in mature T cells. If you don't have T cells, you're not going to find these freaking things. You're going to have decreased receptor circles, okay? So they're just trying to complicate things because they're being jerks, but that's SCID. Second one, ataxia telangiectasia. Whoever named this was trying to get out of work early, because it's not even like an actual name, it's just two symptoms, but it helps us. It helps us because if you look at the name, you know what the disease is. It's going to be something wrong with your B and T cells. You're going to have recurrent infections, yada, yada, yada. You already know that, but you're also going to have ataxia. You're also going to have a telangiectasia. This is due to an ATM mutation, which normally repairs double-stranded DNA breaks. You have a mutation in that you don't repair your DNA, you can have mutations, and so you get all these different systemic signs. But one thing they have in common is you have ataxia, difficulty walking, wobbling. You have telangiectasia, dilated blood vessels. So the history stem, we'll talk about someone with recurrent infections with ataxia. They won't say ataxia, they'll say they stumble around. Telangiectasia, they won't say telangiectasia, they'll say, you know, or they'll show you a picture of a dilated blood vessels. What do they have? What do you think they have? Ataxia, telangiectasia. Name gives it away. So it's a real easy one to get right. Maybe the only tricky thing about this is that labs show increased alpha fetoprotein. Why? Nobody knows for sure. But that might be one of the few ways they can trick you on this question. Third one, hyper IgM. What do you think this is? There's an X-linked recessive, aka only found in boys. Problem with class switching. In particular, is a problem with your CD40. So you can't class switch. You can't class switch, and so your IgM, your default, just stays there. Normal or is increased. That's why I call it hyper IgM. You have decreased everything else. Decrease, what do I want to say? Everything else. So you have someone that has recurrent infections, you draw labs, you see IgM is through the roof. What do you think it is? Hyper IgM. Last one, Wiscott, Aldridge. Another X-linked recessive, holy moly. Mutation in WASP gene. And this codes for a family of proteins actually that help regulate your actin cytoskeleton. and your receptor formation. You have a mutation in this and your T cells are dysfunctional. Your immunoglobulins are dysfunctional, and actually your immunoglobulins will get catabolized, destroy itself. So you get decreased immunoglobulins. Your B cells will recognize this and try to synthesize more. Sometimes it doesn't synthesize enough, it doesn't match the rate of destruction, and so you can get decreased immunoglobulins. Sometimes it synthesizes too much, and you can actually have an increased amount of immunoglobulins. Oftentimes it's increased IgE, IgA. Okay, this increased IgE, what do you think it does? We already talked about it. It can give you eczema. Not only does it affect the actin and the receptor formation of your T cells, but it can also affect the cytoskeleton, and it can also affect your platelets. So they might ask you, what do you see on blood smear? You won't see T cells for sure, but your platelets will be small and rickety. You can have thrombocytopenia, you can get bleeding. So Wiskott-Aldrich is probably one of the more, I guess, difficult to kind of pick up because there's so much signs from everything else, but we'll think of how they might ask it. First, they have to tell you it's both a B cell and a T cell disorder. It's a combined disorder. So recurrent bacterial, viral, fungal infections. So that way you narrow it down to these 4. And then if it has increased immunoglobulins, if it's IgM, then it's hyper IgM. If it's anything else, it's Wiskott. Okay, and then they might ask you, blah blah blah. What's the mechanism? WASP gene mutation, or the inheritance pattern, blah blah blah. Or what else might you find? Eczema, or decreased platelets. Done. Actually, we're not done. I lied. We're done with B and T cell disorders, but I want to talk about phagocyte disorders really quickly. We talked about some earlier. There's one I really want to talk about in particular, and that's Chidiac-Higashi syndrome. This is a defect in microtubules. And microtubules are there for your cytoskeleton, also there to transport proteins, right? So you get the defect in also your protein transport. And the gene that's defective is your List gene, which helps regulate trafficking of organelles, especially things like lysosomes. So why does it cause phagocyte dysfunction? Well, one of the ways your phagocytes eat and destroy things is it fuses with it, transport phagolysosomes to destroy it. You can't transport those, you can't phagocytose those. So, no phagolysosomes. And if you look on a blood smear, those phagolysosomes won't be able to get transported, and they will stay in your cell, and they'll be huge. You get these huge granules. Easy peasy. But the dead giveaway that someone has this disorder, your phagolysosomes isn't the only thing being transported. How about melanin? Don't you also package melanin into melanosomes and transport that out? If you can't transport that out, you don't get melanin in your skin, you get albinism. Holy moly. That's a sign we haven't talked about at all in this blog. So that's like the easiest thing to recognize. That is Chidiac-Higashi syndrome. And then they might ask you, again, what's the mechanism, mutation list, or problem with your microtubules, or a problem with cell transport. Any way to cut it, you should be able to get it. Hope you enjoyed our B cell disorder, T cell disorder, combined, and phagocyte disorder. Hope it clarifies some things. Thanks.